It's the podcast that shakes and stirs up pharmacy. Welcome to PBM on the Rocks.
Hi, everyone. Welcome to the premiere of the Modern Medical Mafia. We at PUTT have been looking forward to this for so long. I am Lauren Young. I'm PUTT's Vice President of our Executive Board. I have been a PUTT member for many years. My father is an independent pharmacy owner in Central Illinois. My sister is an independent pharmacist. I am the operations manager, and I am so excited to be here tonight. We have our friends up just outside Madison, Wisconsin, getting ready for the premiere, but wanted to make sure to welcome everyone to the event. I know that there have been so many people who have reached out to sign up for getting all the information from Modern Medical Mafia to make sure they don't miss 1 minute of the docuseries that we have seen so many bits and pieces of over the last few years. It has been a really hard task to try to get all of these bits and pieces put together and share everyone's stories as best we can. I know that after working in the pharmacy for more than 2 decades, we have patients that really have felt the brunt of this mafia from pharmacy benefit managers, insurance companies, whole gamut. And so really, we're so thankful to the Strauss family, the Schmid family for putting their stories out there, and we really are here to support them tonight. We're so glad for everyone who has submitted information for this documentary, who allowed themselves to be interviewed, who allowed Dan and Mary and Bill to get that story out there. We have been on social media, on both of our podcasts, my podcast, the PUTTcast for Pharmacists United for Truth and Transparency, and also my fellow board member, Jeremy Counts, the PBM on the Rocks podcast. So we have brought on a multitude of guests to try to share the different stories that we have heard about, whether it was on social media and our own stores, amongst our other owner friends. So we are so grateful that you guys have all come together and supported this very, very important mission. And I cannot believe the day is finally here. In just 10 short days from now, this will be totally available online on the Amazon Prime streaming platform. We're so, so grateful to everyone who is able to be in attendance, not only in Wisconsin, but also online. Make sure you go to modernmedicalmafia.com to sign up for all those notifications so you don't miss a single second of the hard work that Mary and Dan and all of our friends on the team have put together for this. No matter what platform you are on, please remember to share this, tag your pharmacy friends, your patient advocate friends. We really want to hit the ground running and make sure that we can get as many different people seeing this as possible, because this Modern Medical Mafia is such an important issue and want to make sure everyone understands the fight that we have been having. Well, I know we are getting ready to throw it over to our friends up in Wisconsin. So again, I'm Lauren Young with PUTT, and enjoy the Modern Medical Mafia premiere.
All right. So my name is Jeremy Counts. I'm an executive board member of Pharmacists United for Truth and Transparency.
And my name is Andrew. I am also a member of the board of PUTT. And tonight we're here to honor those who have been lost.
Yeah. We're here to honor everyone that's out there fighting to actually take healthcare back.
And we're also here to premiere a hard-hitting documentary, The Modern Medical Mafia.
Woo! Yeah.
That's right, everybody.
Yeah. My hard thing about it is PBMs are incredibly evil. Everyone sees this. It's like we think this can't happen in the United States. It can't happen in America. This is impossible. That just doesn't happen. But it is happening. And it really infuriates me. And it makes me wonder, how did we get to this point? Like, how has this not been solved yet?
Really is surprising, you know?
Yeah.
You know what else I think is really surprising?
Lobbying money?
Lobbying money. You doing an event sober. This is exciting.
Oh, yes, that is true. I am actually sober today. That is surprising, but no, Andrew. I think that it is a huge issue that it has fallen now to people like Dan and Mary and what they're doing to try to expose this, because these companies have so much money, they pump all of it in through like advertisers in traditional media. So they'll tell everyone, oh, keep it down. We don't want you pushing this narrative because it hurts us. And well, we pay you a lot of money. And so it's falling, that responsibility is falling to people like Dan and Mary. It's falling to the Schmidnick family. Come up and fight like that. It's heartbreaking and it's not fair.
It's truly unbelievable. And we have so many people that are speaking out, a lot of people here, a lot of people online. And I want to just tell everybody here that's speaking out, getting out there, you're the true heroes here.
Yes, they're going after everybody.
They're coming after us. Then nobody's coming to save us. So
no one's coming to save us.
It's up to us.
It is.
It is. And something like, and a big part of this is going to be the documentary here.
It is.
Yeah,
this is Modern
Medical Mafia.
So
I think
let's do a toast.
I think we should just do a toast.
I think we just do a toast.
Absolutely.
All right.
I think first we toast to the Schmidnick family.
To the Schmidnick family.
Cheers to that.
And to the Strauss family.
And to the Strauss family. And to all of you watching back home.
Everyone back home. And to everyone out there fighting every single day to take healthcare back. Because that's how we do it together.
Keep fighting. Keep standing.
Hello, everybody. I'm Congressman Buddy Carter, and I have the honor and privilege of representing the 1st Congressional District of Georgia. As a lifelong pharmacist, I've seen firsthand the toll that pharmacy benefit managers, PBMs, have taken on America's healthcare system. After all, I was the one that had to tell the mother how expensive her child's prescription was and watch her make a decision between medicine and rent. I was the one who told the senior citizen how much their medication would be and watched them decide between buying their medication or buying groceries. I was the one who watched all this happen, and I knew behind the curtain that the pharmacy benefit managers are the root cause of high prescription drug costs and inaccessible health care. I knew it then, and I know it now, that we have to act. As soon as I got to Congress, I made it my mission to ensure that all Americans have more affordable, accessible, and quality health care. PBMs stand in the way of achieving that goal. PBMs are constantly taking advantage of America's patients, and we must put a stop to it. That's why it's important to talk about how healthcare middlemen are creating barriers to care and participate in documentaries such as these. This documentary will help us shine a light on their predatory practices and continue to show Americans how these middlemen are harming American patients. I'm proud to have been a part of this very important effort, and I look forward to continuing to increase transparency and competition and put patients before profits. I also encourage you to contact your state and federal representative and tell them your story. This is going to take all of us, but we can do it.
Buddy is excellent. Everyone loves the guy. We got hundreds of viewers out there right now tuning into everything we're doing right now. You all have put something great together. We've got great feeds back there. Like, really, I want everyone to give Dan, Mary, and everyone here that has helped put this event together a hand. Like, you all have done great. I'm just sitting here jacking everyone's video feed and sending it out over my own stuff. You all did a great job. And next up, I'd like to introduce one of my favorite people in the world. His courage and what he does and his resolve and really just his fight. It gives me hope and courage every single day. He inspires me. Everyone, my dear friend, Bill Schmidnick.
So I do have a speech. I like to talk. Y'all see me online, but first off, thank you for being here tonight. I want to get this part over with for sure. Thank you for the hometown pharmacy crew that put this together tonight. At that crew, there's a couple special people for Shannon and I as we've gone through this journey or this mission for Cole. How it all started. you know, I mean, I'm not going to go through everything. You know, as simple as that. There was a pharmacy, an independent one in Lodi, Wisconsin. You know, we got to know we were in DeForest first with our hometown actually, and then we moved out to the other way, and we moved to another one. It's been great that way. But as we worked with the Lodi hometown pharmacy, you know, we really got to know the pharmacists a lot. And after Cole's incident, Shannon and I, putting the pieces together, kind of lost. I don't know if you know this or not. I have asthma, exact same as Cole. I mean, we could switch medicine, simple. I threw my prescription in after Cole's incident. We didn't even know what happened at this point. And Shannon went to pick up my Advair at a pharmacy. I think her friend Chris was with her. And we got the true taste of the PBM greed and tactics. I was on the same insurance as Cole, by the way. So exactly the same difference. And I'm not going to say that all chain pharmacies are bad, but the staffing from the cost of medicine causes even those guys to be bad. But then you got the other side of it too, your independence. And long and short of it, the pharmacy is there, will not Shannon leave without my medicine. And I have a feeling full well she knew. Remember Dan talked about that little step process and that under reimbursement. I'm almost positive the whole time. I think it was 12:45. You closed that one. You stayed late even, knowing probably in your mind, I'm going to lose money on this, but I'm going to get it for Bill. Are you stinking kidding me? I mean, where was that for Cole? Why would we needed that for Cole? It's got god darn PBM greed. That's what it is. $500 billion a year. Are you kidding me? I've heard this. It's more money than small countries, for Christ's sake. And my son's dead. There's other people dead. There's businesses going under. And some of you are in this room. Some of you are online, and it's across the freaking country. You've heard from Jack from NCPA. You've heard over and over. Pharmacies are closing. People aren't getting their medicine. The profits are going up. And then there's still Cole. And long and short of it, Cole was Cole. Cole wasn't perfect, but Cole was awesome. Cole had a dream in life. And Shannon's kind of told this. You guys might have heard this. I'm sorry, but Cole wanted to be a gamer. He wanted to lift weights and then sleep and live with his roommates from elementary school. Cole was damn near at his dream. He figured out, I got to work 40 hours a week too. And he chose not to lift weights, but he did live with his roommates. And he gamed 6 to 11, 5 days a week with a special event on Fridays, and that's all I'll say. Long and short of it, Cole was living his dream. Simple as that. Okay. Losing Cole has been the hardest thing our family has ever done or had faced. There are no words to describe how it leaves us. As we remember him today, I want to ask you all to carry forward the lessons Cole taught us. And what is that lesson? If Cole taught us anything, if you know somebody or whatever, simply just be happy. Just be happy. And that's one thing that he always left with us. And even in this tragic thing, we live with it every day. It's hard some days. And Cole's just be happy message. We will find a day when it's really easy to do that. That's a guarantee. Yes.
I'm Shannon. I'm angry mom. Just kidding. Bill's angry dad on TikTok, in case anyone wants to start following him. So as Bill said, we just wanted to really honor Cole tonight, but we also want to make sure that everyone knows tonight we understand Cole is kind of the agent of change tonight. However, this is so big, much bigger than our family, much bigger than any of us in this room. But we also know that Bill and I fight, more so Bill, he's in the public eye much more than I am, but fight for Cole's memory. But we do so by making sure that this never happens to anyone again. The fact that someone has to pass away because he can't afford his medication in the United States of America is unacceptable. Couple people that I know Bill especially, and I wanted to thank real quick. I'm sorry we're going to call you out, but we do want to thank Donna. I don't know if you understand. And I know we see you all the time, but man, you are like our little angel. Without you, without that day that I came to pick up Bill's prescription, I will never forget that day. And you taking the time to make sure the same thing didn't happen to him. I remember so distinctly leaving your pharmacy and you helping me, and you even called back. I mean, you're amazing. And thinking, oh my God, this is what happened to Cole, except he didn't have it, Donna. So thank you. And then just lastly, again, Bill, thank the Strauss family. Thank you, our friends and family. Thank you all for being here. Most importantly, please listen to the words in this documentary. The next step is to act. We have to do something after today. We can't just be angry and sit. We have to act.
Hi, I'd like to thank Dan and Mary Strauss for their work in creating Modern Medical Mafia. This documentary exposes the price gouging abuses of the drug pricing middlemen known as pharmacy benefit managers. PBMs take money out of the pockets of seniors, taxpayers, and pharmacists by marking up prescription drugs by thousands of dollars above their acquisition costs. Last July, at the House Oversight hearing on PBMs, I introduced the bipartisan Pharmacists Fight Back Act with Representative Harshbarger, a pharmacist, to crack down on their price gouging abuses. Pharmacists Fight Back is the most muscular reform ever introduced at the federal level. It will implement a transparent pharmacy reimbursement model using market-based pricing benchmarked to the national average drug acquisition cost. It will end patient exploitation in federal health care plans and impose criminal violations for such behavior. I look forward to introducing it again this Congress. Local pharmacies are the cornerstone of our downtowns, and I'm grateful to Dan and Mary for giving local pharmacists a voice in this documentary. In some areas, they serve as their community's primary healthcare provider. There is a local pharmacy going out of business every day in our country. That undermines our main streets as well as our healthcare. I've heard from local pharmacists all over the United States that the Pharmacists Fight Back Act is the reason they will fight to keep their doors open, despite the Fortune 20 abuses they have to face every day. I'd also like to take a moment to remember Cole William Schmid, who passed away on January 21st of last year. A Big Three pharmacy benefit manager had increased the price of Cole's daily asthma medication from around $35 to over $500. Cole was forced to choose between paying for his rent or his medication. Cole's death was entirely preventable. Last Congress, we reached 60 bipartisan co-sponsors for the Pharmacists Fight Back Act, including Representative Buddy Carter. This Congress, I will encourage my fellow members to protect patients like Cole and to pass PBM reform.
All right, I promise everybody we are very, very, very close to getting to this documentary. We only have one more little speech to go, and it's from a very important person, somebody that's very important to this docuseries. It's my pleasure to introduce to you Mary Strauss.
Andrew said he wouldn't blame me for being late, but I'm sorry. I am the reason we are late. And for good reason, because I was trying this is the first episode of the docuseries, by the way, so this isn't everything. Over the last 6 months, we got 90 hours of conversations and incredible information for America to make a difference, to not have anyone else die. And so the last 3 months have been cutting that 90 hours into 4. Hard. And so I squeezed everything into our first episode that we'll watch today, but it kept on cutting out on Cole's story. And so that was not going to be acceptable. And but we got most of the episode The whole episode is an hour and 10 minutes, but I got an hour and 7. So if it cuts out randomly, it's on a fine spot. Just means you have to watch it on Amazon later on. But Dad wanted me to bring up what was the inspiration behind doing this documentary in the first place. And it all started back in 2019 when I still lived out in LA. I think I just finished film school, and I was home for the summer, and we were having a conversation in our kitchen, and we just switched over to self-insurance at Hometown. And he was talking about pharmacy benefit managers and how people need to know about the abuses they cause and the people they harm every single day. And I'm like, he wrote all the different ways through DIR fees, clawbacks, gag clauses, rebates, etc., all on like 10 or 12 napkins. And we made our first video back in 2019, trying to explain it. And it's just way too much for everyone to understand how they're being hurt every single day and how they can make a difference. And so after that video, I said, we need to make we need to make it something bigger, something more long form, so people can truly take the time to understand. And so COVID hit right after that, and everything was prolonged, and for good reason. Not good reason in terms of everything that's happened since then, but the momentum that's building around PBM reform and everything that will hopefully make a difference. So no one else has to die, no more independent pharmacies have to close, and no more people like you and me have to suffer each and every day from the lack of care and healthcare, besides what I've grown up with the last 20 years in independent pharmacy and seeing how many people are affected in a positive way and their lives changed from having cancer and diabetes and everything under the sun be reversed because someone took the time to try and take care of you. And so if this docuseries can save another life, can save another pharmacy, can save America and healthcare in any way, shape, or form, this is pretty cool. And so just going around and talking to the incredible people who are in these 4 episodes, and everyone is in it because there's people in the crowd who are in the docuseries. You have your time because everything that is said is so important.
Most Americans haven't heard of PBMs, and I was no different a few years ago until I started to dig into this industry.
When we feed the beast, all we're doing is strengthening the beast.
They have a lot of money.
That's what this is. It is monopoly. It's smoke and mirrors. PBMs are strong. They're powerful. A lot of money, and they spend a lot of money.
PBMs are probably the biggest companies that you've never heard of.
Healthcare sort of being the most corrupt industry in the country. It's extortion on a daily basis.
The United States has the highest drug prices in the world, by far. The United States is the only country that has PBMs.
According to the Fortune 25 companies, United Healthcare PBM is number 4. CVS Caremark is number 6. And then Express Scripts is number 16. 3 of the top 25 companies in America are PBMs.
Well, police say this was definitely a targeted shooting, and they now believe the motive could be a grudge against the insurance companies.
We have PBMs claiming to reduce prescription drug prices. And on the other hand, we have the Federal Trade Commission, the New York Times. We have at least 8 different attorneys general, Democratic and Republican, who all say that PBMs are inflating drug costs. I wonder whom the American people should believe.
Give us the truth, the whole truth, and nothing but the truth, so help you God.
Your companies steer patients to affiliated pharmacies, yes or no?
The answer is no.
Dr. Costner?
No, sir.
Dr. Conway?
No.
You're under oath to tell the truth, and they lied.
Questioned by Congress and they lie to them, what are they doing to everybody else?
Where they can control regulations, they can control the way agencies look at regulations, the way they look at practices, and they can pave the way.
They control the data, they control the formularies, they control the rebates, they control the costs. They have positioned themselves so that they control everything.
If you're a patient, you walk up to that pharmacy counter, you're paying $400 for something that your insurance company might be getting $350 back from. $330 billion of fluff that exists between sticker prices and the real prices of medicines after all the discounts are happening.
That's why what they're doing is what gangsters do.
The mafia is small ball compared to what PBMs do. The scale that PBMs do it, the brazenness that they do it, and a sophistication.
My son died because he could not afford his insulin.
Our son Cole was 22. He had gone to the pharmacy to pick up his discus, and it was over $500. Sunday, January 21st, he passed at 10:06.
People are dying because they can't afford their medication. You all are part of the problem.
So they just are destroying independent and community pharmacies.
I made more money on a regular cup of drip coffee than on 40% of the prescriptions I filled in 2024.
And pharmacists are the most accessible healthcare professionals in America. Last year, 300 independent pharmacies closed. When it comes to healthcare, whether you're Republican or Democrat or independent, we all want the same thing. We want accessible, affordable, quality healthcare.
You have a thing called the middleman, you know the middleman, right? The horrible middleman that makes more money, frankly, than the drug companies, and they don't do anything except they're a middleman. We're going to knock out the middleman. We're going to get drug costs down at levels that nobody has ever seen before.
Although it may not look like a battlefield, it's not guns or knives drawn, the harm is just as great. Killing people, causing people to suffer without any consequence.
Every one of those PBMs takes our patients away from us. They harm patients. We have to stand up. Those that can speak up should speak up, and we're speaking up.
My name is Dan Strauss. I'm a little bit of an odd duck, and maybe the person that's main job is to translate complexity into Main Street. I started my career as an accountant for a Big Six accounting firm, and I only bring that up because every 3 weeks we went to a different type of job, and with that you knew absolutely nothing about that industry, and you learned to ask smart people questions. And at the end of 3 weeks you became intelligent subject because you asked questions. And when it comes to healthcare and PBMs, etc., it takes a lot of questions, and we're also trained in healthy skepticism. Trust but verify. And what you'll find out later when it comes to healthcare, there's a lot of trusting on false assumptions that nobody verifies and turns out not to be true and harms an awful lot of people. And then I had a good friend about 22 years ago that stated that he wanted to be able to buy 5 pharmacies. And I looked into it, and pharmacy is a very odd business, as we'll find out later. But we went in with a very core mission of pharmacists. You take care of patients and get patient outcomes. I'll take care of you to make sure we're solid. And we were very much pragmatic, right? We are your typical Main Street, rural type of farm community strong. We do a lot of things ourselves. Turns out folks liked our style. So we went from 5 stores to 7 to 12 to 17, then we ended up to 70 pharmacies. And we had our own health plan, and in our own health plan we had the same issues that everybody else did. That our premiums were going up 15-20% every year. We'd look into it and says, well, that's just the way it is, and you couldn't afford that, so what would you do is you would raise co-pays, lower benefits, and that same song and dance for too many years. And then we have the 1 year where we supposedly had a good year where we didn't spend as much, and they said, well, you're still going to get a premium increase. I thought something is absolutely wrong. In our own health insurance plan, we started digging deep. And then that's where we started finding a lot of issues that we'll get into later. When you're a pharmacy on Main Street, you get to meet an awful lot of people. I'm very, very proud of our pharmacists because we have a reputation of really taking care of people. And with that, people tell us what's happening to them. And it's absolutely soul-crushing and mind-numbing, the things you see and says, this just cannot be right. So the first time you hear something, you says, well, that must be a one-off. Then you hear it again and again, says, no, we got a problem here. We need to start asking questions. And then you look around the country, ask questions, no, this is actually worse than I thought. And this whole mission of this docuseries has been an explosion of that, where we think there's 10 things wrong, it's really 20, right? So it is complex, but the nice thing is when you ask enough questions and you trust and verify, now you can find a way to take complex situations and break it down so we can explain it to our family and friends on Main Street in the big town of Rye, Wisconsin, a population of 1,100. You know, there's a couple of very personal experiences that I think a lot of folks can relate to. First, I'm going to talk about on the patient side, then two is an employer with the health plan side. So the first one, we have a wonderful aunt that all of us dearly loved. And she used to come in the pharmacy, and she was on a generic medication where her copay was $10. And she would come in the first of the month with $20. She'd buy her medicine, but then also buy $10 worth of candies and goodies. And on her way home, she would stop and visit 10 different folks to just spread a little love and a piece of candy. One January, she comes in, and her insurance company said, you no longer can get that generic medication for $10 that you've been on for the longest time. Now you have to take a brand, and it's going to cost you $75. She still only had $20. So now she's in tears. We see that. There's no way we're going to let her leave without her medicine. But there's where it's like, this is wrong. How can a good generic that did the job well for so many years all of a sudden not be good enough? And you realize it's a form of extortion. When people are forced to pay more for the price of drugs, this is healthcare. You know, this is just wrong. So that left a deep scar and created an awful lot of questions. Then secondly, our own health plan. I had to fight for almost a year with our health insurance company to say, I'd like to know my spend on pharmacy. This is our own medicines coming off our own shelves, given to our own people. Well, we can't share that with you because of HIPAA. No, I don't want individuals' names. There's nothing about HIPAA. I know how much came off our shelves in dollars, how much that cost our own health plan. And I almost had to threaten a lawsuit, and finally I got it, and I realized why they kept it a secret. $60,000 of medicines came off our own shelves and went into our own people's hands, and our health plan charged us $360,000. Now, that is just wrong on so many levels, and that was the eye-opening moment. If they're doing it to us, what are they doing to everybody else? And we realized we just came upon a nugget of information that most folks never have privy to. They aren't marking up 10%, they aren't marking up 6%, they're marking up 500%. Who's benefiting? Them. That's like a skim off the top. Them are health plans and PBMs. So PBMs started out back in the late 60s and 70s to simply be a paper pusher. The simplest form to say it is when health plans start covering prescription medicines, let's say company X and company Y each said, well, there's 100 pharmacies in my network, I don't want to write 100 checks. And the pharmacies themselves says, well, I don't want to get 100 checks from 100 different companies. So PBMs were simply in the middle to say, okay, company X, write me your entire check, and so will 20 other companies, then I'll take that and then I'll write the checks to the pharmacies. Well, that works. It was great for the third-party administrator, for the employer, and pharmacies, we liked that to begin with because it made life simpler. That's why they existed for so long. And why nobody ever heard of them, because whoever hears about the paper pusher that's doing this. Well, as we'll find out when we talk about history, they went from a paper pusher that had no regulation into the most powerful folks that impact the cost of medicines, and now are literally extorting people because they have the benefit of not being understood. In our journey, we find that if you talk to 100 people on Main Street, often less than one has ever even heard of a PBM, much less know what they actually do. Everybody knows there's a problem. Who's the bad guy? How did we get here? Where did they come from? How did they get away with it? And that was the inspiration of making this docuseries, is we had to explain who's doing it, how do we fix it, and how do we get here? This whole docuseries is actually meant to solve that core. The question is, will you believe us? So what I'm so proud of is the number of highly qualified, highly intelligent people that know intimate details that want to share that with the audience so they know this is truth. In healthcare, we all want to believe that's the one area of our country and you just want to trust, right? There's inherent trust. And I want to make sure we're very, very emphatic here. Doctors, nurses, pharmacists, they're amazing people. They get into healthcare for the right reasons. They're in to take care of the patients. The unfortunate thing is many of them are forced to work for organizations that people will never meet, make the rules, make the decisions, and up at the C-suite level, we call it, that's the CEOs and CFOs, board of directors, whose responsibility is to their shareholders, that their job is to make money for their shareholders. And so the way the game has been, I won't say rigged, because as we'll go into it, a couple great pieces of federal legislation that was well intended had loopholes. Those loopholes allowed for very savvy business folks to exploit and operate under the radar and unfortunately hurt the rest of us.
Hi, I'm Doug Hoy. I'm the CEO for the National Community Pharmacists Association. I'm a pharmacist. I grew up in community pharmacy. My dad's a pharmacist and practiced for several years before coming to NCPA. NCPA, we're the National Community Pharmacists Association. We've been around for over 100 years, and we represent independently owned pharmacies, the small businesses. Some people say the mom and pop shops, but the community pharmacies, the almost 19,000 of these community pharmacies throughout the country. Our mission is to protect and preserve independent community pharmacies. So the reason we need to protect and preserve independent pharmacies is to help patients and their communities, because we see so many patients that don't fit into the big, what I consider assembly line of healthcare. You know, not all patients are the same. They have different needs. And I think in our healthcare system, we try to put patients on an assembly line where all the patients are the same, they need all the same things and all the same care. And I think that really jeopardizes the health of millions of patients. Our independent pharmacies, they are the ones who will take the time, and they're a safety net for the millions of patients who just don't fit the mold of assembly line healthcare. The PBMs, their history, it's kind of interesting. That they were created in the late 60s, early 70s. And back then, prescription insurance was still a new thing. A lot of people didn't have prescription insurance yet because prescriptions were still not very costly. They were still pretty inexpensive. But as time went on, there were more breakthroughs with prescription drugs, and some of those prescription drugs started to cost more money. Patients would pay for the prescription drug and then have to submit the bill to their insurance company and wait to get paid back. So the concept, at least on paper, of PBMs was actually something that was good. It allowed patients to be able to submit their insurance claim on the spot. Pharmacies were some on the cutting edge of technology. So the patient knew right away what they were obligated to pay and how much their insurance company would pay. The patient didn't have to submit and wait for their money to come back. And for the pharmacy, it was, at that point, it was helpful for the patient, so it was good for them, and it allowed that pharmacy to get paid in a timely manner. The cost back then was a transaction fee, which I think was in the pennies for this transaction fee, and that was the end of it. And it was also transparent. Here's your transaction fee. I don't know the number, but let's just say it's a nickel. You paid a nickel, and for that you gained some efficiencies, and everyone's happy. I wouldn't think there'd be a lot of regulation needed back then because it was a simple, straightforward task. The original idea was a good idea, and it was a processor that created some efficiencies in the marketplace. So the early start of PBMs was not a bad thing. It's changed. PBMs are like the weeds of the lawn of pharmacy and the pharmaceutical world. They are everywhere. They're invasive. A preliminary report from the FTC reported that just 6 make up 95% of all the prescriptions that are paid for in America move through those 6 PBMs. And breaking it down even more, 3 of those 6 PBMs account for almost 80% of every prescription. So patients, pharmacies, pharmaceutical manufacturers, payers, they can't make a move without talking to these 3 PBMs that account for 80% of all the prescription traffic in the country. And all 6 of these, by the way, not surprisingly, are PCMA members. PCMA, they're the Pharmaceutical Care Management Association, a DC-based lobby group. So PBMs have, I can't count how many revenue streams that they have. Even if I could, they mask those revenue streams and won't disclose them. They don't make the medicine. They never actually touch the medicine. They don't provide any pharmacy dispensing services. They make more money than the providers on either side of the equation. So yeah, they are the quintessential middlemen. They're the paper shufflers, but they've got everyone by the short hairs because they control the data, they control the formularies, they control the rebates, they control the costs. They have positioned themselves so that they control everything. But no, they make money from the pharmaceutical manufacturer, they make money from the payer, they make money from the pharmacy, they make money from the consumer. There are fees galore for the pharmacy and also probably for the payer as well as the manufacturer, and hidden fees to the consumer as well. Oh, it's like a license to print money to be a PBM.
You have a thing called the middleman, you know the middleman, right? The horrible middleman that makes more money, frankly, than the drug companies, and they don't do anything except they're a middleman. We're going to knock out the middleman. We're going to get drug costs down at levels that nobody has ever seen before.
PBMs were created as a middleman to help reduce the price of prescription drugs. The PBMs are not doing what they were created to do. They're not saving the patient money. They're actually costing the patients more money. They're price gouging, and in addition, another part of our investigation, they're stealing patients from independent pharmacies.
We're on pace this year to lose one independent pharmacy every day.
Yeah, we lay out in the report what some of those declines have looked
And I
like.
might point out that, you know, whether you're Republican, a Democrat, or independent, we all want the same thing. We want accessible, affordable, quality health care. Pharmacists are the most accessible healthcare professionals in America. If one pharmacy every day is closing, accessibility to health care is going to be impacted. How much a price of a drug goes toward the pharmaceutical manufacturer and how much goes to the PBM. I'd like to submit for the record a report by the Berkeley Research Group that shows that 37%, only 37% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 63% go?
And put patients before profit.
Take a look at these photographs. These are real people, real patients. They exhibit only a fraction of the Americans who are taken advantage of by PBMs every single day. We have an opportunity right now, an opportunity to advance bipartisan legislation that increases reporting requirements, which would heighten transparency and shine a light on the opaque practices of these PBMs. When I was in high school, I wanted to be a football star. Unfortunately, not only was I short, I was also slow, so it just didn't work out. And I made a deal with my dad. I told him, I said, Dad, after my junior year in high school, if and playing football, if University of Nebraska or Oklahoma hadn't sent a scout out to see me, I'll get serious about a career. And I don't know what happened, but they didn't show up. But anyway, I got serious about a career, and after my junior year in high school, I got a job in a drugstore and as a delivery driver, and it was really an omen from God because I just it was perfect for me. Healthcare, obviously very extroverted, so I enjoyed working with the public, and I knew exactly what I wanted to do. And I went on my senior year, and then went and got my pharmacy degree, and came back home and got a job in a drugstore and I worked for 8 years as for someone else, and then decided I wanted to give back to the community, to give back so much to me. And I volunteered. I served on the Planning and Zoning Committee, and next thing I know, I ran for City Council, then I ran for Mayor, then I ran for State House, then I ran for State Senate, and then I ran for Congress. So it really is the all-American story. I mean, I've lived the American dream, and I just want to give back to a community that's blessed me so much. And it was my primary focus as to why I wanted to go to Congress. Remember, I practiced retail pharmacy. I was the one who had to go to the counter and tell the senior citizen how much their medication was. I was the one who watched them make a decision between buying their medicine and buying groceries. I was the one who had to go to the counter and tell the mother how much the antibiotic was for their child, and watch the mother in tears as she was trying to figure out how she was going to pay for that antibiotic. I set as my goal and my focus to do something about that. And I knew where the problem was. Yeah, the pharmaceutical manufacturers need to do a better job with their pricing. There's no question about that. But the problem lies within the drug pricing chain. And the problem lies within the vertical integration that exists, where the insurance company owns the PBM, the pharmacy benefit manager, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. That vertical integration is what was leading to the increase in drug prices, and I wanted to do something about that, and I set as my focus to do that. The first thing I did 10 years ago when I got to Congress was go straight to the FTC and say, why aren't you looking at this? Why aren't you looking at the fact that the insurance company, aka Aetna, owns the pharmacy benefit manager, aka Caremark, that owns the pharmacy, aka CVS, that owns the doctor, mini clinics. And another example, Cigna, Express Scripts in this case bought Cigna. The PBM actually bought the insurance company. But Express Scripts, they are the PBM, Cigna's the insurance company, and then you got a group purchasing organization, that's part of it as well. Then you've got the pharmacies. Express Script mail order is by volume, I think, the second largest in America. And then you've got the doctors. In the case of PBMs, there are 3 PBMs that control 80% of the market. United Healthcare, according to the Fortune 25 companies, United Healthcare is number 4. United Healthcare PBM is number 4 in way of revenue. CVS Caremark is number 6. And then Express Scripts is number 16. 3 of the top 25 companies in America are PBMs. The FTC, their role is to make sure that there are no monopolies out there. And again, as I point to the vertical integration, United Healthcare, I think, is another good example, because United Healthcare is the insurance company. They're also the PBM. They have the group purchasing organization. They have the mail order pharmacy. They also have doctors. They are the largest employer of physicians in America is United Healthcare. 9% of all physicians work for United Healthcare. Now, there's nothing wrong with working for United Healthcare, but 9% of all the physicians in America work for an insurance company? What's wrong with that? Those kind of examples have really caught the attention of many of my colleagues in Congress, and there are many more examples out there like that. And that's why I feel like we're making so much progress right now. We've got them on the run, but now let's face it, they're big companies, big corporations. Number 4, 6, and 16 in the top 25. They're not going to go down and just lie down without fighting. They're going to fight hard. But I really do think that transparency is going to be the key. If we can show what's going on here, then I think there'll be a call for changes. No question in my mind, it's an unlevel playing field. Timing's everything. I was very blessed and very fortunate when I came into the profession because, PBMs were just processors. All they did was process prescriptions. They didn't have formularies or anything like that. And all you had to do was be nice to people and take care of them. And you were successful. And then it evolved over time. All of a sudden, PBMs discovered that, hey, there's a formulary here in this hospital. If we can have an impact on that formulary, and then we can capitalize on it. And please understand, I get it. I know we live in a capitalistic society. I'm not opposed to anybody making money. However, in this case, they are ripping off the public, and they are causing prescription drug prices to be high. And they're not bringing any value to the healthcare system. There was an article in the Wall Street Journal just recently about Gleevec. Gleevec was it cost $55, and yet CVS was charging over $7,000 a month for that. Now that's robbery. And about spread pricing. We all know about spread pricing, about how an insurance company or a PBM, same thing, how they will buy medicine for $5 and charge $10 for it. And that's the spread pricing in that. And there have been a lot of states, and we've made a lot of success in the state levels as well. And a lot of states have sued the PBMs as a result of this. In fact, the state of Ohio, the Attorney General, sued Express Scripts. because of the spread pricing that they were doing on the state Medicaid program. And he referred to the PBMs as gangsters. That was his words, not mine. But he referred to them as gangsters. And what they're doing is what gangsters do. They are ripping off the public and not bringing value. Now, they'll sell it as being, oh, we're keeping insurance rates down by using that money. My insurance premium hadn't gone down. I don't know about yours. But that's just smoke and mirrors.
It's a modern form of barely legal gangsterism.
AG David Yost filing a lawsuit claiming pharmacy benefit managers linked to those companies, or PBMs, the so-called middlemen of the industry, have set up a subsidiary in Switzerland to share drug pricing and rebate information with competitors, pushing prices higher.
It's, in effect, price fixing. It's anti-competitive.
It's what President Biden railed against during the State of the Union.
We pay more for prescription drugs than any major nation on earth.
Biden has touted his Inflation Reduction Act for capping the cost of prescription drugs like insulin for seniors on Medicare at $35 a month, calling on Congress to extend the cap for all Americans.
But Big Pharma has been unfairly charging people hundreds of dollars, $400 to $500 a month, making record profits.
At least 3 pharmaceutical companies have now lowered their insulin costs, but for many people, price relief on other drugs has been hard to come by.
Today, Cigna Express Scripts, a Fortune 20 health insurance company and pharmacy benefit manager, announced that it was suing the Federal Trade Commission to redact the FTC's report on its price gouging practices. Why might Cigna be so embarrassed by this FTC report? Maybe it's because they don't want people to know that they're charging Medicare beneficiaries $3,613 for a cancer drug that costs $65, or that they're charging Medicare beneficiaries $3,534 for a multiple sclerosis drug that costs $10. I can keep going, but you get the idea.
Perspective, right? It's saying, look, this is all I'm going to have to pay, right, for this benefit. We look at the benefit from a different perspective, which is what is the actual cost of the drug, and build up from there, which is what's spitting out at the end. What's the actual cost of this stuff, so that you can have a better understanding of what a guarantee should look like. I got hired at the Pharmacists Association, really still beginning the infancy of my career. That's when I got introduced to the complicated world of pharmacy, at least the money side of pharmacy. As a technician, I had no idea, really what was spitting out when I would help check somebody out at the pharmacy counter, right? In retrospect, the pricing at the pharmacy was a casino, right? Not because of the prices that were necessarily set by the pharmacy, but what insurance companies and companies called pharmacy benefit managers, which I didn't know at the time, how they were computing the prices despite what a pharmacy was charging. So my time at the Pharmacists Association quickly evolved into a government affairs capacity, where I started to learn about the complaints of pharmacists, the complaints of patients, and public policy intersections with the profession of pharmacy. Within that role, I started to learn more about drug pricing as a whole. And what I learned, what I assumed is that pharmacists who are educated to a doctorate level now to know everything there is to know about a drug, its interaction with your disease state, how it works in conjunction with other medicines, and what I thought the business that governed the transaction, what I learned is that the expert that we trust to know the most about the medicine, including the finances of it, are actually passengers in the pricing vehicle, right? And to me, I found that to be incredibly compelling, that pharmacists who are supposed to be the experts don't actually have a relevant influence on what the prices are that are charged to an employer or a patient. And that set me off on a journey to learn everything I could about the proverbial layer cake that is a pharmacy transaction. When a grocery store puts an item on the shelf, they get to name the price. And if they price it too high, they won't sell a lot of that product. If they price it too low, that means they won't make a lot of money. So the beauty of traditional retail markets is that they respond very much to our wallets and our purses, right? The companies need to find this perfection equilibrium point of how much can I charge and still remain competitive and also sell more of that product such that the end consumer will maximize the amount of value that goes to that retailer, right? That's why even though we might have publicly traded companies that are involved in the sale and distribution of milk, bread, eggs, cereal, you name it, their fiduciary obligation is to make more money. One would assume that in light of that, they would just charge $50 for a box of Cheerios, right? Well, they don't. The reason they exercise that restraint is not because they're do-gooders. It's because they won't make as much money if they overcharge for that product. So our impact as consumers is to create a sobriety around the prices that are being charged. All of a sudden, you go to that same grocery store, but go to the back corner where the pharmacy lives, all those traditional economic rules don't apply because the pharmacy is not setting a price with the idea that a cash-paying consumer can afford it, because the cash-paying consumer no longer governs that transaction. And what I mean by that is that in the regular side of the grocery store, cash is king. The impact of the consumer and their wants and desires are what hold prices down. So the question then becomes, why is it that when you get to the pharmacy, those rules no longer apply and the prices are sky high? That's not a reflection of the pharmacy as much as it is who is the customer when it comes to the purchase of a medicine. And even though it is a patient who's walking up to that counter, today over 95% of prescriptions are being facilitated and transacted through intermediaries, health insurers, and pharmacy benefit managers who have actually taken the role of the economic pressure, if you will, on pharmacy prices. Now, what do we know about those industries? They're heavily consolidated. They have a lot more power than an individual consumer. So the question then is, if individual consumers are so effective at keeping the prices of grocery goods and all retail goods to a sober level, why is it that when you move to the pharmacy, the PBMs have been so unsuccessful in pressuring what would be a reasonable price commensurate with the underlying cost of that product? And the lesson there is that they don't actually want low prices. What they want are high prices and big discounts, which very well could be lower than what the marketplace would yield if everyone had to price their products reasonably. But PBMs make money not off of low prices, but off discounts from high prices. If I walked into Giant Eagle and the gallon of milk was $20, I would say Giant Eagle is ripping me off, right? So what will I do? I'll start, saying if the other things that I buy in my life are also overpriced, now I'm going to start looking at Kroger. Now I'm going to start looking at other grocery stores. I'll look at an independent, whatever it is, all right? But what if, let's say, milk is too expensive everywhere, right? Let's say every grocery store was all of a sudden overcharging for that product. What would I do? I'd look for an alternative product, right? Myself as a consumer, the decisions that I make to purchase or not purchase creates pressure such that the milk supplier and the milk retailer all have to understand that in order to sell more product, they're going to have to be reasonable with the charges that I see at the end of the transaction. That does not occur in the pharmacy world, where the patient is often told, you have to go to this pharmacy, and you, at that pharmacy, you will be exposed to this price. It is an atypical transaction from anything else we see in traditional retail environments. I think insulin's a great example here, right? You have a patient that is life dependent on insulin, and what have we learned? That insulin is unilaterally too expensive across the board, driven by a number of factors, most notably a growing disconnect between the real price and the list price of that medicine. If I was a diabetic, I couldn't just simply say, well, no more insulin for me today, right? That's a fast track to death. So the reality is that the patient is often a captive consumer because they don't have choices to just delete their diseases, right? Or decide, hey, I'll take a medicine that doesn't actually help me. So there's a tremendous curation, if you will, of choice, because we as patients need what we need. Patients get different types of coverage in different aspects of the marketplace. If you were a patient on Medicaid, insulin had been and continues to be essentially free. Medicaid, which takes care of the poor and underserved, does not impose a tremendous amount of cost sharing on individuals who need a drug. When you move into the Medicare sector and the commercial sector, different rules start to apply. Many commercial plans are high deductible health plans, which means that from a patient perspective, you have to spend a certain amount of money out of pocket before your coverage really kicks in. There are a number of plans in Medicare that essentially have operated within the same policy realm. So what that means is that when you're a patient and you're in a plan that requires you to pay before you hit a deductible, that means is that you're being exposed to the list prices of those medicines, the going rate. You have no erosion to the cost exposure that the system is yielding. So despite the fact that insulin was clipping at $35 or $40 after you tabulated all the discounts, many patients would walk into their pharmacy and ultimately get charged $300 or $400 for that vial of insulin. So let's spell this out like very simply. All right, insulin's list price was around $300 or $400. After all the discounts the drug company gave up, that product was actually only valued at $35 or $40. Yet those discounts weren't flowing through to patients. Instead, they were floating to someone else. So I'll use an analogy here. Imagine if you were a consumer and you were in the market for a new dishwasher or a washing machine. Most of us are familiar with a rebate in that sense, right? You go to your local hardware or appliance store, you look at the different options available to you. Some are priced, as is. Some products might have a rebate. And after you sit down and look at all the different options that are available to you, you all of a sudden decide that a product that has maybe a $1,500 price but a $300 rebate, that's the right one for you. So you walk up to the cashier, you pay the $1,500, you fill out the form, and voila, a rebate comes back to you. If for whatever reason you sent in the form for that rebate, and let's say your neighbor were to grab the check out of your mailbox, that would be them stealing from you, right? You were overcharged for that product. If for whatever reason the manufacturer chose not to send you that rebate check, that means you were overcharged for that product. So in traditional retail settings, we understand what a rebate is. I overpay to get some value back that lowers the net cost that I incurred for said product. Again, not in the pharmacy world, where a sick patient who's already saddled with a lot of medical bills and other sorts of diabetic supplies that they need to keep up with their ongoing disease management walks up to a pharmacy counter and is told by their insurance company or their PBM that you will be charged $400 for something that is generating hundreds of dollars in rebates, that is going back to the very company that has told you to overpay for that medicine. So if you're a patient, you walk up to that pharmacy counter, you're paying $400 for something that your insurance company might be getting $350 back from, right? So you, the patient, are the one that is the origin point of that rebate. In our world, we call that money from sick people, where a sick patient overpays for a medicine that generates a rebate that is ultimately collected and harvested by somebody other than the patient who had to foot the expensive bill in the first place. In a simple way of characterizing it, when you overpay for a medicine and it generates a rebate that goes somewhere else, that somewhere else is usually the PBM. The pharmacy benefit manager is a large company that ultimately determines which drugs will be covered under your benefit plan and which ones won't. Because of that, because so many of us are getting our medicines through insurance, drug companies have a big vested interest in the decision-making process of PBMs, and thus are willing to cough up big bucks in exchange for opening up that market access. There was a report released just this year, 2024, by the Drug Channels Institute that quantified the value between the list prices of medicines and the real prices of medicines after all those rebates are accounted for. That gap has now reached over $330 billion. $330 billion of fluff that exists between the sticker prices and the real prices of medicines after all the discounts are tabulated. Yeah, a lot of people, have, I think, a pretty negative perception of the oil and gas industry, right? Without giving it a pass by any stretch, because I'm underinformed. The beauty of at least gasoline is that we have a tremendous amount of transparency into what the price will be. And we know and trust the price we see up on the big board, right, will ultimately be a reflection of traditional competitive forces. If I see that a gallon of gas is going to be $3.15 a gallon, right? Well, I can trust that I could probably do a search of every gas station within a 1-2 mile radius, and nobody's going to be around, $2, or nobody's going to be around $4, right? I can trust that competition is going to pressure prices in such a way that they'll ultimately be a reflection of reasonable competition. Furthermore, that price that lives on that board conveys trust, right? And you look at the drug marketplace, that ain't the case. We're working on a study right now looking at Medicare prices, where we're looking at the different prices that are being charged within different plans where the drug program is run by the same PBM. And we found that for some PBMs, they have over 600 different prices for the same drug over the same time period. The range of the highest price to the lowest price can be the difference of $6,000 per prescription. Same NDC, same time period, same PBM, right? Different plans. But you're looking at 600 different prices with a range of as much as $6,000 between the highest and the lowest price. The interesting thing is that everybody's been very upset about the prices of insulin over the years, for good reason, right? We know very well insulin's origin story. It was essentially a patent that was given away for almost nothing, with the idea that this is a true public service, right? This is something that people really need. Now, it's unrealistic to assume that a bunch of manufacturers are going to grab that patent and essentially start making insulin for free, right? There's costs associated with that. And furthermore, publicly traded companies have to make more money. Regardless, we over time saw a good amount of competition in the insulin space. We know brand companies that don't face competition, they're going to be able to charge whatever they can get away with, right? The idea from an American perspective is that we've granted a patent, and if you as a drug company bring something new and innovative to market, something that didn't exist before, you have the right to charge essentially what the market will bear, because we want to reward you for bringing something to us that is materially better than what existed had it didn't if it wasn't on the market before. So that's the trade-off, right? We want manufacturers to bring us cures. We want manufacturers to bring us things that make our lives better, continue our lifespans. And so we give them incentives through patents such that they have the right economic incentives to do that. Insulins are a great example. We have 3 big manufacturers that offer comparable insulin products, one versus another. In that instance, those companies can't necessarily take the liberties that are provided to somebody who has an orphan drug, if you will. So what do we know about competition in all other, economic marketplaces? Is that competition works to increase quality and lower price, or some intersection between the two. So with insulin, what you saw over time is that rather than competition working to lower the prices of those products, insulin manufacturers competed to raise their prices almost in lockstep with one another, while simultaneously increasing the amount of discounts that were provided to payers in the marketplace. Now, some of that is driven by government programs who mandate that they get massive discounts off the list prices of medicines, but a huge component that was driving the disconnect between the list price and the real price of insulin were big rebates that were offered by drug companies to PBMs in exchange for preferential treatment on the formularies, where the PBM decides which drugs will be covered and which ones won't, which ones will be preferred. versus which ones won't. So what you saw was not a race to the bottom on the price, you saw a race to the top. So you saw something that was $10, $20, $30 decades ago turn into a product that became $300 or $400 over time. Now the drug company, what we found from Senate Finance Committee investigations, as the list price went up over time, you actually saw diminishing returns for the drug company. In fact, what you saw was that after you tabulated all the discounts that the drug company was passing through to government programs and to PBMs in the marketplace, the actual underlying cost of insulin was going down. It doesn't just impact them from a financial perspective, right? Although that financial perspective is big deal. We have seen patients who are making trade-offs all the time in order to keep themselves well. They'll decide to ration their insulin. They'll decide to forego diapers, groceries. They'll decide to forego other things in their life in order to afford the very thing that keeps them alive. Unfortunately, I'll rewind the tape back to when I worked in pharmacy as a technician. I used to see instances where if you told a patient their copay was $5, there are some people where that is unacceptable and untenable. I've seen many patients leave a pharmacy because a $5 or $10 copay was just not within their budgetary availability. Now, when you think about insulin and how life dependent it is and how many people it impacts, right? We're not talking about the difference of $5 or $10 at the point of sale. You're talking about hundreds of dollars where people will make decisions that have, in many instances, has caused them to go to the hospital, incur other sorts of losses in their life, or to actually, worst case scenario, die from that problem.
A group that tracks drug costs says about 60 companies increased the price on almost 300 medications. The price of insulin, a life-saving drug for diabetics, tripled between 2002 and 2013. Since 2008, 3 top manufacturers raised the list price of insulin at least 10 times. Anna Werner shows us one state's plan to rein in soaring costs and one mother's personal fight.
My son died because he could not afford his insulin.
Nicole Smith-Holt's son Alec was 26. He had just moved out of his parents' home and was starting a life of his own.
The hardest part is every time I tell the story, it's like reality slaps me in my face that my son is no longer here.
People are dying because they can't afford their medication, and you all are part of the problem.
The answer is simple. The dominant 3 PBMs put stock price over health. Well, I can go on and on and on about the big 3 PBMs. They are everything that is wrong with this industry.
The big 3 PBMs are CVS Health, OptumRx, and Express Scripts. The influence of PBMs recently impacted a Wisconsin family.
Our own Shauna Johnson has more on the tragic story and the fight for more regulation of PBMs. Shauna?
A bill to regulate pharmacy benefit managers never made it to vote in the Assembly, but families and independent pharmacy owners from across the state say legislation is needed to save lives. Unfortunately, it's already too late for one Wisconsin family.
Yeah, don't.
I don't want anyone to ever have to experience this.
Our son Cole was 22. Essentially, when I was pregnant with Cole, we knew he would have asthma because Bill and I both have asthma. Our doctor had said there was a better chance of this baby having asthma than not. So we were prepared. He was officially diagnosed, I think, probably around 18 months. I remember as a baby him having, the little inhalers with the chambers back in the day. That he had a yellow one with bears on it. I can remember. Kind of grew up knowing what an inhaler was, how it helped him. There were plenty of ER visits where he would struggle in certain seasons, or when he was, I don't remember the exact age, but maybe preteen, he was prescribed a daily steroid medication. But actually, we both were prescribed it as well. And I always say that that was life-changing for all 3 of us. Cole was able to play sports. He was able to live a normal life. He had that discus every day, and he was good. He moved out on his own probably about age 20. He had moved in with his childhood best friend up in the Appleton and Green Bay area. He was doing well. Cole struggled for many years with school issues, ADHD, severe depression. So it was really great to see him go out on his own and finally find his people in the world. He was finally happy and doing well. He was working full time and just happy. It was amazing. He had texted us on a Monday and was having trouble breathing. He had texted Bill. He was trying to use his nebulizer, which again is something we had for years at the house for times when he needed it. And he was texting Bill that he was struggling with the tubing or whichever. Bill had told him, I can drive up, whatever you need. I don't know how to help you over the phone. I'll come up and see you, whatever you need.
About 45 minutes later, he had actually called me. And his biggest concern was, what insurance do I use?
To go to the ER.
Yeah, to go to the emergency room. Because I could hear his labored breathing. I mean, me having asthma, I could tell exactly where he was at in his asthmatic attack. And I just get chills still thinking about it. I just said, get to the hospital. I knew there was one close. I said, call an ambulance, do whatever you need to do to just get there. Just go to the hospital. Don't worry about insurance. He had told me that his roommate was actually at the house that evening. He drove him to the emergency room. As soon as Cole hit the cold air outside, though, it was 22 degrees below zero roughly that night. It was one of those deep freezes in Wisconsin, and that really triggered his asthma.
The emergency room was like 6 or 7 minutes away only.
There was a lot of ice on the roads. On his way there, his breathing got worse, and he actually went unconscious in the car. Yeah, Mitchell had grabbed his hand and was trying to feel a pulse the whole way there. And the last minute or so, he said that there was no pulse. And when Cole did arrive at the emergency room, he was lifeless. They had to resuscitate him to bring him back.
We later found out that he had suffered a cardiac arrest in the car, is what we assume had happened, which is why Mitchell could no longer feel a pulse.
As we got a message from Mitchell, I actually got a call from the doctor in the emergency room, and we did drive up, got up there about 1:30 in the morning. And
the doctor had told you he was on a ventilator at that point in ICU. So we knew it was not good. I remember packing up a bag, because, you just think you're going to be gone for like a day. Because it'll be fine. And I was like, this cannot be happening. This cannot be happening. I just kept repeating that over and over and over. He had asthma for 21 years. I just kept telling myself, like, what is going on? Because again, 21 years of managing his asthma. He knew how to manage it. I did not understand. But we took Bill and I and his brother, who had just turned 17 at that time. Yeah, we got in the car and horrible road conditions, icy January night. I just remember so freaking cold and icy on the roads. But, you remember like every detail of all those days. I remember every detail. But we walked in. I remember Bill pushing the button on the ICU floor or whatever. And I remember Bill saying, like, who we were and we're here to see our son. I just was no. And walking in and seeing him on that ventilator, we just...
Yeah, it was just, yeah. I mean, it's
unreal. It's like a night. I mean, it is a nightmare. It still is a nightmare.
When they went to resuscitate him, they couldn't even get a tube down his throat because
his airway was so closed. And Joel had told us, you're going to be in for the long haul here, so get comfortable. There were concerns right from the get-go about brain damage because he had gone an unknown amount of minutes without oxygen. Mitchell, his roommate, who just holds like such a special place in our heart because he was with him for those last minutes, did his best to be a reporter. And, here he's 20 trying to give details of the worst probably night of his life, his best friend dying in his car. So they had very, scattered details, and that the next, I think they had said, 36 to 48 hours were crucial at that point. But Cole ended up being in the ICU for 6 days. And those were obviously the worst 6 days of our lives. We went from, hey, we see some hope, there's a little bit of brain activity. I remember him telling us, like, you're not going to get the Cole back that you knew. But we were like, that's fine. We'll take him however we can have him. And so they're like, okay, we're going to keep monitoring. He was so heavily sedated, obviously still on a ventilator. And then the next day, that Dr. Long would come back and say, he had us standing by Cole's bedside, I remember. And 2 of the most amazing nurses were behind us. And I just remember Dr. Long, saying things like, what we thought we saw, the hope we thought we had, starting to and I remember we grabbed hands, and I remember the nurse pushed a chair up behind me because she knew we're going down. And we did. Because he just said, there's no hope. This is it. He's going to be ventilator, feeding tube dependent. This is what you see this is all you will ever have of your son.
It's a blur, but I remember just collapsing
You
right in the
did.
bed.
Yeah. Yeah, you collapsed on his chest, and we couldn't believe it. The day prior, we had just a glimmer of hope. That day, we started to have conversations about end of life. They had told us that Cole was an organ donor, which we did not know. So we're super proud of him for that. I know it seems dark to be joking about stuff, but Cole was such a quirky kid, and I can literally picture him at the DMV being like, do you want to be an organ donor? And I imagine him being like, do I have to pay for that? And if it's free, then sure, put me down. All these other families are getting the best phone calls of their lives that an organ donor is available for them, and we're told, oh, Cole has, amazing organs. Well, no shit, he's 22 years old. Of course he has amazing organs. This isn't supposed to be happening. The only thing they said he couldn't donate was his lungs, because they were so hurt. So on Friday of that week, we had our family come and say their final goodbyes. By that Sunday, the hospital did an honor walk with us for him to the OR. And he donated what he was able to donate. And Sunday, January 21st, he passed at 10:06 p.m. Even at the ICU, his roommate was there, his best friend, Mitchell. And so he was our only kind of source of what the hell happened. And it was Mitchell who told us he was out of his medicine. And we're like, what? How? Why? How? And Mitchell had said, yeah, we went to the pharmacy. Mitchell had gone with him because Mitchell was picking up something as well on the Wednesday prior. Mitchell said, yeah, we went to the pharmacy. And he said, I don't know, Cole went up to the counter and came back and showed me on his phone that it said $539.18. And Cole was like, I can't afford that.
That same medicine for a 90-day supply last year was $70.
When Mitchell told us that, we were like, what? Again, your mind just starts spinning, no. He must not have given him his insurance card. There had to have been a mistake. This cannot be. So we had, that's the only little piece of information that we had that could have led to this. We didn't know how, why, what brought us to that $500 price tag. And within a matter of 5-6 days was in the ICU. And still just not knowing.
That was tough. And the way we found out about it was kind of
a fluke.
Yeah, fluke.
Yeah.
I have asthma, like I mentioned earlier, and Shannon was in town with one of her friends in a small town by us, and I asked her to swing by a pharmacy and get my discus. I get a call from her saying that my discus isn't covered anymore, and that the pharmacist was, however, trying to find something else, and the pharmacist there wouldn't let her leave.
Yeah, I remember her, she specifically said, I'm not letting you leave with nothing. And it was then, that I kind of was like, wait a minute, this is sounding eerily familiar, right?
Yeah.
Bill and Cole worked for the same company, they had the same insurance, so literally everything was the same medication, everything. And I was driving home, and my friend Christine was like, what's going on? And I'm like, this is what happened to Cole. This is it. He just, A, didn't know to ask questions. He was 22. But B, he went to a pharmacy where the pharmacist didn't take the 5 minutes like Bill's did to say, whoa, wait a second. You need to breathe. So let me figure this out. They were like, well, it's $500. You got that or not? And Cole said no. And that was next in line. And I remember so vividly sitting in my friend's car, my mind again just spinning, holy shit. Cole, this is all it would have taken? Like, are you kidding me? This is all it would have taken for Cole to have gotten his prescription that day? This cannot be okay.
You know, and obviously the clarification on this is Cole went to a chain pharmacy that's very large,
understaffed,
possibly, very heavily involved with PBMs at times and whatnot. And I chose an independent pharmacy. And there were two drastic outcomes.
Drastically different outcomes.
Mm-hmm. Yep. Well, the pharmacist agrees with us, what we were talking about over the weekend. We think that something shady happened. We'll just say that. I think that was kind of
contributed
to Cole's death. I mean, there was an outside factor that did it. And that was Saturday. I got a call about 3 or 4 o'clock on the Monday. And that's, I think, kind of when our world really just...
Mm-hmm.
When holy shit, something really did happen to Cole, and we got to do something. That pharmacist actually called me and wanted to introduce me to you, Dan, and knew your mission.
We had a call from one of our pharmacists saying that one of her patients, Bill and Shannon Schmitnecht, had a tragedy, and they're just starting to learn about PBMs. Can you reach out to me just to be able to help fill in the blanks, just help them through this time? Well, of course, that's what independent pharmacies do. We take care of folks. So I got invited over, and I got a chance to sit in the kitchen table with Bill and Shannon, and that is, I'll say, 2.5, 3 hours that changed my life, that made this, that we have to do this. They had the ultimate tragedy that should never, ever occur, and created incredible pain for the family and for almost everybody they touched. So I made it a point to myself on the way from their home back to home. I called up my daughter's a filmmaker, says, Mary, you were right. We have to make this film. This has to be done, come hell or high water. Because people are dying now. We knew it was going to happen, but now it did. We didn't do enough ahead of time to prevent this, and we're not going to let this happen again. And legislators, I don't care if you don't understand it, or you don't have enough backbone to fight it, or you're getting paid too much. Enough of that. We're going to make enough people know what's happening that hopefully the rest of society comes and says, this is enough. We've seen so many terrible things happen in the last 6 months that shouldn't happen, but they have because so many people are hurting. And they're hurting because they're getting extorted, they're getting ripped off, they're getting manipulated, they're going bankrupt because they shouldn't. Because 3 parties have gotten so damn greedy that they're taking the rest of us for a ride. And now that we know what's happening and that it can be fixed, we have to do this. And I think the reason why we didn't do it sooner, people are scared. If you are a pharmacist or a doctor, you are scared for fear of retaliation. The name of this movie, Modern Medical Mafia, wasn't by accident. I'm a fan of movies. And when you watch things like Godfather, and you watch documentaries, the mob of the 20s, you think of what must have been like to be that shop owner in New York where you had to pay protection money. How horrible would that be? Then I woke up one day saying, holy crap, we're it. We're getting started every day. We get all these fees and manipulations, and then we're scared to say anything because if we do, they kick us out of network and we can't serve our customers at all.
When we feed the beast, all we're doing is strengthening the beast. The beast, it's anyone who breaks the golden rule. It's anyone who is really looking for a seller win and a buyer lose.
Right here, this is where it all happens. The circle of death.
It's almost like murder in a way.
They have a lot of money.
That's what this is. It is monopoly. It's smoke and mirrors. PBMs are strong. They're powerful. A lot of money, and they spend a lot of money.
A lot of backroom tactics, a lot of bullying, collusion. It is absolutely a real thing. There isn't any question that mafia tactics exist in healthcare.
The mafia is small ball compared to what PBMs do. The scale that PBMs do it, the brazenness that they do it, and the sophistication going against the biggest companies on earth with literal armies of lobbyists through things like steering, games with rebates, drug pricing, manipulation, drug pricing arbitrage, year in, year out. session in, session out, and you see how many bills die. There's oftentimes writing their own regulations.
All the tactics are there because they need to make more money.
Complete lack of transparency.
But they didn't tell us they were doing it until we walked in the pharmacy. That's what we've learned. It's all greed. It's all greed. Greedy, profit, but deceptive, non-transparent tactics.
PBMs are probably the biggest companies that you've never heard of.
Healthcare is sort of being the most corrupt industry in the country. It's extortion on a daily basis.
People who could die as a result of being refused care.
Well, what did everyone think? I am so excited to get to see so much of the Modern Medical Mafia premiere, get to see so much of Mary's hard work. That was incredible. I loved getting to see what we have been working for so long. My favorite part, obviously, was getting to see some of the legislators talk about what we heard in hearings. As everyone knows, I'm the legislative guru at Pharmacists United for Truth and Transparency. So anytime I get to hear snippets and clips from those different hearings and getting to watch the PBMs at the table squirm a little bit while they are flat out lying to Congress and other legislators is entertaining and infuriating. So that's what I look forward to seeing more in some of the next episodes from the Modern Medical Mafia, which you can get starting January 21st on Amazon Prime. So don't forget to stream that and sign up for the notifications on Modern Medical Mafia. When you're on Modern Medical Mafia, you can also share that mission and try to get as many of your network and your friends connected, because there is a real passion for the March to 1 million. Everyone knows that if you have a store full of patients, store full of employees, you can have them talk to 3 to 5 people, and you can easily get to 1,000 people in that network, and getting that to push out through more and more and more of your network to help us reach 1 million voices strong, so that we can get legislators, we can get other patient advocates, we can get other healthcare professionals who really do care about what is going on in the PBM reform segment. They want to help save community pharmacies. Wanted to remind everyone that on Capitol Hill, there is a huge bipartisan push for this. So please don't forget about the Pharmacists Fight Back Act. Just wanted to remind everyone that, again, you can go to Modern Medical Mafia. Right now, you're watching a tribute video to Cole Schmid, Bill and Shannon's son, who tragically passed away because of PBM greed. The 1-year anniversary of his passing is coming up on January 21st. So that day is very special. You can always track down Bill at Angry Dad WI on social media. Definitely reach out, show him and Shannon some of the support that they so greatly need as that first anniversary comes up. It's always very hard, very trying, but Bill, Shannon, we are with you. Wanted to remind everyone again, the bipartisan efforts would not be possible without every single one of you reaching out to your legislators. There is a lot of momentum that we have heard and we are continuing to see on Capitol Hill. There are legislators who have never before been interested in PBM reform and listening to their pharmacists and listening to patients in their district. So definitely do not lose heart. Continue to make those connections, continue to send information, and try to educate those in your circle, especially about PBM reform and how it can best help patients in your community. That's our goal. Wanted to remind you that PUTT was founded 11 years ago because of different pharmacy owners and different patient advocates that were they saw the writing on the wall and they were trying to move the mission forward, that there is no place for the PBM reign of terror any longer. So again, you can check everything out that you may have missed. You might need to go back and watch some more of the Modern Medical Mafia premiere. You can share this on all of our social media platforms. You can check out Pharmacists United for Truth and Transparency. TruthRx.org has a great member resource library for anyone who is looking for more ways to get involved. We look forward to the March to 1 million with our friends from the Modern Medical Mafia. We are so thankful for all the support. Thank you to Jeremy and Andrew from the PUTT board who were able to be the on-the-ground troops there in Wisconsin tonight with our friends from the Modern Medical Mafia. Again, so much love to the Schmidtniks, Strauss families. Please continue the fight. We look forward to all of working towards this mission for the foreseeable future. Watch out, PBMs. We are coming for you. PBM reimbursement reform is coming. We look forward to this. Everyone have a great, safe rest of your